But now we have this new class of really highly active, these advanced topical therapies that are really exciting. And I guess the first, if we're going to focus on PDE4 inhibitors, let's talk about what that means. Like phosphodiesterase 4. Can we talk about that enzyme, Dr. Leo? And will you just let us know what that enzyme does and why inhibiting it leads to an anti-inflammatory response?
It is such a cool enzyme. It really is. So as I understand the history of it, I believe Dr. John Hannafin at Oregon Health Sciences University back in the 80s was one of the first people to really pick up on this part of the inflammatory pathway, because we know atopic dermatitis is fairly complex. There's a lot of different mediators. Now we know all the cytokine, at least many of the cytokine names. We know about IL-4, IL-13, we know IL-31, the master itch cytokine, all these things. But it turns out that part of that cascade after those cytokines, it is mediated by phosphodiesterase 4, this enzyme that's playing a role in driving this inflammatory cycle. So it turns out that it's pretty focused too. It's not playing a role, for example, in making white blood cells or something like that, right? Because we know some things, if you tinker with them, you can have myelopenia or anemia and all this kind of stuff. So this is the classical Goldilocks problem in medicine. And we're lucky when we find them, because we can shut everything down. Arguably, that's what corticosteroids do. You shut down a whole bunch of systems and boy, you sure get better, but there's a major price to pay if you overdo it. Even things like cyclosporine, or to some degree the calcineurin inhibitors, which work similarly. They block a little bit more broadly, although I would argue much safer, of course, than some of the alternatives. But here, PDE4 is so targeted to this general pathway that we find that we can block it without a whole lot of adverse effects. It doesn't seem to bother other systems, but it does all the big pieces we want. Decreases inflammation, decreases itch, and allows the skin barrier to heal, which makes it really great in atopic dermatitis, really good for psoriasis too, and even in seborrheic dermatitis. So that actually we know Roflumilast, the newer agent, that actually has 3 independent indications, which is pretty amazing. It's, I think, to my knowledge, it's really one of the only topicals outside of steroids that has 3. Others might have 1 or 2. But we really see 3. But we also know in the case series and reports, it's gigantic. There's all these other things people have used it for, everything from lichen planus to other inflammatory conditions. And that tells me again that this is maybe the perfect Goldilocks pathway. And Dr. Hannafin was 40, 50 years ahead of his time.
Yeah, so when we look at PDE4 just in the inflammatory cascade, it's responsible for converting CAMP to 5-AMP, if I'm correct, and that by blocking it, right, we're able to increase the concentration of CAMP intracellularly, which decreases pro-inflammatory pathways like NF-κB. We deal with MAPK as well. Like there are multiple pathways that are pro-inflammatory that are affected by just increasing the CAMP levels, the cyclic AMP. And that's where it's really interesting, because in addition to its efficacy, and like you said, we already have 3 disease states for which it's indicated: seborrhea, psoriasis, atopic dermatitis, down to the age of, what are we, 5 now, Peter? For
actually down to age 2. Finally, we got it down to age 2 for atopic dermatitis, which is so cool.
Thank you. Down to age 2, and we're working on the 3 months.
Yes,
right,
if we look at the cousin, crisaborole, another PDE4 inhibitor, that goes all the way down to 3 months. So exactly right. I think with Roflumilast, we're hoping we'll get that down to the same level as well.
There you go. So we're working on that. And it's so great to tell patients and parents, look, this is indicated down to the age of 5. We're working on, or down to the age of 3, and we're working on less than that. And, that just gives a halo of safety, doesn't it, when you're talking about that?
Amen. I love that same piece, because even to talking to an adult, it's like, actually, we use this in little kids. And I think that it is reassuring, and it should be, because, right, it's a lot of work getting a drug approved in kids. You do actually have to take the studies on again. Each time you do that, weird stuff can come up. So there is a bit of a risk. And I'm grateful, because especially half my practice is pediatric. I'm used to most everything I do in kids is off label. It's really unfair to the kids. They don't get the same level. So when a company bothers to do it, it is so nice to be able to say, yes, they really did study it in little kids. We really can have something to say about this, and I'm grateful.